Greetings and welcome to this edition of Berkeley Conversations. I'm Dan Mogila from the Campus Office of Communications and Public Affairs. The rollout of the COVID-19 vaccines has generated a wide range of reactions, concerns, and questions. Amid the relief and protection vaccination is bringing to millions of people, there's been confusion surrounding access and scheduling, dismay about equity, questions about efficacy, and for some, lingering resistance or hesitancy about getting the shot. To help us sort through all this, we're lucky to have an excellent panel of experts with us today. They include Dr. Erica Pan. She is California's state epidemiologist and the deputy director of the Center for Infectious Diseases. She is joined by three faculty members from UC Berkeley School of Public Health, the co-sponsor of today's event. We have with us from that school, Dr. Art Reingold, the division head of epidemiology, Dr. Colette, also known as Coco Arswald, an expert in adolescent and community health, and Professor Osagie Obasogie, the Haas Distinguished Chair and Professor of Bioethics. As always, we welcome your questions. You can just post your query at any time to UC Berkeley's Facebook Live streaming site. And so without further ado, let's get started. And I want to begin by going around the room, and I'm going to start with you, Dr. Pan. You're news consumers like the rest of us. What are you noticing? What's got your attention? What are you thinking about specifically in terms of vaccines, the rollout, and the evolution of the whole process?
That's a lot of questions on one. What am I thinking as I'm hearing what the news is? And I apologize, my dog is barking in the background. I had to work from home after all today. I am thinking that I'm really excited actually about this opportunity that we have. And, this is an anniversary day. I just need to note as well. Around this time, a year ago, I was talking to my then 6 Bay Area colleagues, including Dr. Hernandez, your City of Berkeley health officer, and we were realizing we were really, really worried about the numbers that were happening, and we were making the decision to be that first stay-at-home order in the whole nation. And we've come such a long way, and never, if a month or two after that, you had told me we would have vaccine here in California at the end of December with over 90% efficacy and 100% protection against hospitalizations. I mean, it's pretty amazing. So I just want to kind of highlight how exciting that is and how far we've come. And to have 3 excellent vaccines and more on the horizon is just really, really exciting. So I think that is one thing that I would say that I'm really thinking. And, I acknowledge that, yeah, the bump out was rolly. It was in the middle of our biggest surge in the middle of holidays. We have healthcare and public health staff that are exhausted. They were already exhausted. It's already been another 3 months, but we're doing amazing as a state. And we're getting more and more vaccines into arms and just really excited we have this opportunity. And I think if people can just really, hang on until it is their turn, if it hasn't been their turn yet, and continue to do all the important, masking and non-pharmaceutical interventions, we are really close. We're talking very actively right now about what that green phase after this blueprint looks like. And I think we'll be ready to talk more about that very soon as well. But if people can just hang with us a little bit longer, we are really seeing the light at the end of the tunnel.
So I want to follow up on something before I turn to the other panelists with this opening question, just to channel folks who are watching today, listening in right now. You said we're doing amazing in California, but I think if you look at the media reports, a lot of people have the impression that there remains confusion and uncertainty about equity issues and distribution and all the rest. What is it that you think people don't understand or that the media is getting wrong about the situation in California right now?
Yeah, I think when you look at us compared to other large states and you think about how diverse of a state we are and how, we have everything from LA County to Mono County or, a Sierra County with 3,000 people in it. And we have a huge geographic spread and diversity as well. So I think we just have a lot of different challenges. We also have 61 local health departments. And I've, again, been fortunate enough to work at the local level for many years and now really excited to be at the state level. But it's been fascinating, again, to see we've really built on the autonomy and local authority and flexibility in California as far as that need to have that at the local level. But, it's really demonstrated in this pandemic how we need to really strengthen our consistency and collaboration statewide and having more infrastructure that really is statewide. So I think a lot of early on, at least getting good data on, where the vaccine is. And even still now, there's just a lot of challenges. We still have 3 different immunization registries. We don't have one statewide. We just allowed a lot of different things to come together and haven't had, for example, the IT infrastructure. So that's a huge thing I think people don't realize. And the media, it's really different to look at, a small state with one large state health department and a few little satellites versus ours. And so I think that's one just huge thing to keep in mind. And I think when you look at us compared to other large states, we're doing quite well on par. I mean, the ranking will parse out whether or not we've vaccinated, 10.1% versus 10.3% of our, population. Or, I think we're hitting 4 million people fully vaccinated today. Really exciting. That's 10% of our population. That's a higher proportion of our over 16 and up. So I think, we're on par. It is challenging. It's not simple. I think, people need to kind of be patient as well with the process, and that we have been very decentralized. So we're trying to, again, balance meeting the needs of people where they are, but also having some consistency statewide.
Super. Thanks so much. That was a really great answer. Usagi, I want to turn to you. What's a bioethicist thinking about these days as you read news about the vaccine rollout?
Well, the things that I think about mostly are framing and access. So how do we frame the public conversation around vaccine distribution? That is, how do we think about who is in desire of the vaccine and who is not wanting it? And so, as you all have probably read about, there is a burgeoning conversation about certain members in minority communities who are resistant or hesitant to take the vaccine, and how that kind of shapes the conversation about kind of where certain initial distributions to go, and how we think about making sure vulnerable populations have access to this. And so, as an ethicist, I always want to kind of interrogate some of those initial assumptions around hesitancy to see if they're actually empirically accurate. What some of the more recent studies are showing is that some of the initial conversations around vaccine hesitancy, particularly in the Black community, aren't exactly accurate or true. That is to say that there are many people in the Black community and other minority communities who are just as anxious to get access to the vaccine as anyone else. And so we have to, rethink and kind of think carefully about how these framings about hesitancy might unduly limit the ability of these communities to have access to these medicines. And then the other issue is just access itself. That is to say that, are these communities are they part of the conversation about making sure that they are seen as being not only worthy of, but targeted as populations in need of this vaccine? So this is to say that this is not only a question about race or ethnicity, but also about age demographics. So one of the concerns I've had is that so much of the registration for getting access to the vaccine has been online. And not every age demographic is as capable to kind of navigate that online process as other kind of younger demographics. So we have to find ways to make sure that everyone can have the ability to sign up and get vaccinated, and that the process is something that is available to everyone, and that there are multiple entry points. So online is great for some populations. Some populations might require things such as, door-to-door notice or door-to-door vaccination, community spots, churches, barbershops, things of that nature. Just making sure that we have multiple ways of being in contact with people so that they have the opportunity to be vaccinated.
So before I roll on, it's been a roller coaster ride with the vaccines, I think, just in terms of public sentiment. We heard they were coming in this record-breaking time and everybody, vaccines. And then a few weeks later, it was vaccines. Where do you think we are now in terms of the lens, Usagi, that you're looking through at all of this? Are things improving? Or do you think every day sort of brings a new wave of concerning news for you? Or are things getting better now? How are you feeling about the situation you just described?
I'm feeling optimistic. At the beginning of this year, I say late last year and beginning of this year, as we were having public conversations about vaccine distribution, particularly with regards to the conversation around the Black community, the initial framework was, well, because of Tuskegee, Black folks aren't going to want to take this vaccine. And I think that framework is starting to change because people are actually starting to talk to Black people. They realize that, one, that while many community members of all racial backgrounds have certain concerns about whether or not scientific developments in medicine are actually safe to use, that's something that I think everyone across the board is kind of thinking critically about. Black folks aren't any more hesitant than anybody else to kind of be able to interpret information, to learn about what the vaccines are and how they help their body, and make rational choices about what they need to do to protect themselves and their family. So I'm seeing that the conversation is changing a bit, and that people are realizing that if these vaccines are communicated in a way to all populations that reasonably describe their efficacy and their benefits, and these vaccines are made available, that people will participate. And so I am excited about that, and hope that we will continue to make sure that the vaccine distribution is an inclusive process and not one that is based upon quite archaic understandings of how certain communities think about science and medicine.
Got it. We're going to come back certainly to the issue of hesitancy, resistance, and equity. And I'll just point out before I turn to Coco for her own take, last week there was an NPR PBS poll, a Marist poll, that found 73% of Black people say they plan to get the vaccine or have done so already, as opposed to 70% of white people who say they plan to get the vaccine or have it already. So just putting some numbers behind some of what you just shared with us. Coco, let me come to you now. What do you, as somebody who has expertise with adolescent health and community health and is right there at that intersection of public health and clinical medicine, how are you processing? What are you thinking? Where do you think we stand these days in terms of the vaccine rollout?
Well, like Erica, I'm a pediatrician. And so I've been thinking about vaccines for a long time. And I know vaccines, have changed our way of life. But I also know that to get vaccines to folks in this setting so rapidly, and to everyone, not just to children, we need a robust bottom-up system that works for everybody. And I think one thing that I'm seeing is that it's really not one vaccine plan. We need many vaccine plans. We need vaccine plans that fit all the intersectional identities of folks and all the different types of lived experience. The vaccine access for people who are disabled and housebound is going to be different than the vaccine access for folks, who are able-bodied and going to Whole Foods, and different from folks who are in rural areas and are depending on clinics that maybe aren't even really open right now. So there's really huge differences. I think there are multiple divides for each of these subpopulations, and those divides increase in number and become more and more complicated as people are more and more marginalized. So as you know, I work primarily, my area of focus is with people experiencing homelessness, and those folks experience not only what I call houseism, so sort of the devaluing of people who are homeless, but also most often are experiencing racism because of the disproportionately Black and brown nature of that population. They're also experiencing more likely to be LGBTQ, more likely to be excluded in other ways, criminalized, et cetera. And so all those things are going to make it more difficult for them to access vaccines. They're also are going to have fewer degrees of separation to people who have been hurt by systems or more likely to have been hurt by systems themselves, and more degrees of separation from people who can answer their questions. So people in general are making the best decisions they can based on the information that they have. And it makes a big difference how many degrees of separation, how much social capital they have to access those things. And I would say the last thing I would say is that I think about this really in an eco-social way. So what's happening at each level? What's happening at the level of the vaccine? This is an unstable vaccine right now that needs 2 shots. And can't be, the dose expires after 6 hours. So, you have really systemic issues associated with the vaccine. You have issues associated with individual comfort, not only with access to information, but what are the basic needs that people might have? What's going on at the family level? Do people have a vulnerable family member? Whether they have access to tech or not. And then things that are happening more at the systems level, like Erica said, health systems that are highly stressed, and dealing with a limited vaccine supply, fearing of wasting doses. We have a doctor who was charged with giving a leftover vaccine to a family member when that vaccine would have expired. So how is that making people feel? And so I think there are multiple divides that people are facing, that we all have seen, just even for those of us who've been vaccinated, what was the role of our privilege and our access to resources and being able to do that. So anyway, that's a lot of responses. I think it's really multi-level, thinking about things from the bottoms up, because no one from the top is going to be able to plan it all, and having inclusion being at the center, and then other things we can talk about later.
And so we shall. Thanks so much. A lot of food for thought in that initial answer. Art, let me ask you to sort of cap off this initial round where you sit. I know you're consulting with the campus and the state and the feds. This is sort of your bread and butter epidemiology. Probably never expected a year like this. From where you sit, how does it all look right now in terms of the vaccines and the rollout?
Well, I would agree with Erica, and I hope you can hear me. I would agree with Erica that the glass is much more than half full, even if we haven't vaccinated more than 50% of people yet, that we really are on a very good trajectory. I think we need to put it in perspective, not only with how quickly the vaccine was tested and shown to be safe and effective, and large numbers of doses being produced and made available, but the fact that fundamentally, one of our problems is we don't have a single health system the way some countries do, and we don't have one public health system. We basically have 50 states and a half a dozen territories and tribes, each with its own health system, public health system. So, Erica pointed to the complexity within California, but we also have the problem of, 2 states right next to each other that are playing by totally different rules. And it's very confusing to people, very perplexing for people. Why is my cousin Fred eligible in this state, but I'm not eligible in my state? And so I think people misunderstand that somehow we're one country when it comes to public health, and that's really not true. So I think we are actually doing reasonably well. For me, it's a little frustrating that 2 good committees last summer thought deep and hard about how to prioritize limited numbers of doses and how to roll them out in an equitable manner, looking at mortality, looking at disease reduction. The ACIP did this, and the National Academy did this, and frankly, I wouldn't say those efforts have been completely wasted, but by and large, political pressures and all kinds of other pressures have largely driven almost a constantly evolving set of priorities of who should get vaccinated before someone else, and that's still happening today. So I think it's remarkable we're doing as well as we are, frankly, particularly in comparison to a lot of European countries that have a single health system, a single public health system. So I would be upbeat rather than downbeat.
Got it. I'm going to follow up, and I'm going to ask the same question of Erica after you answer this next one, Art. You touched on this whole idea about the federalist system, the federal government, the states, all the rest, and it begs a larger question. have we learned something new about this country, about our competency, about our weaknesses, about our strengths, about our healthcare system? What have we learned through not just the vaccine rollout, but the pandemic in terms of the healthcare, public health, clinical medicine context? What have you learned through this?
Well, I'm far and away the oldest person on this panel. And while some people don't believe it, I've actually worked in public health at the local level, at the state level, at the federal level before becoming an academic. And I guess what I would say is I think we've once again relearned a number of lessons. None of them are new. And I'm not sure whether they will change us, for an ongoing basis. But we have learned that we need to be better prepared for problems like this. We have learned that we need better coordination. We have learned that we need better infrastructure at the state and local level when it comes to registries, when it comes to technology, when it comes to personnel. But these are lessons we've learned multiple times in my 40-year career. So will we heed the lessons on an ongoing basis? Check back in a few years.
Got it.
Yeah, Dan, if I can jump in.
Please go ahead.
Yeah, so I really I agree with everything that Art just said. And I think there's another layer of complexity. And that is that I think many Americans don't have an adequate understanding of what public health is. That is to say that many Americans think about health as an individual experience. And I think that confused so much of the conversation over the past few months. So for example, the conversation around masking, unfortunately got trapped into a broader national political conversation about whether you're left or right. And I think that was part of it. But I think for many people, the idea of wearing a mask was an individual choice where they thought that, well, I'm willing to take the risk, or I'm low risk, therefore I don't need a mask because my health is not implicated. And there wasn't a deeper understanding of the idea that when you wear a mask, you're not only protecting yourself, but you're also protecting other people. And that conception of public health was missing from so much of the conversation. And that's what many people just didn't understand. And so I would hope that this opportunity this experience that we've had with COVID-19 is an opportunity to educate people on public health. That is to say that we not only need to take care of ourselves, but we need to take care of our community, and that we need to do things to protect each other, such as social distancing and wearing a mask. And my concern is that with the broader distribution of the vaccine, that will play into existing conversations and dynamics around individual health, rather than seeing the vaccine as part of a broader strategy of public health. And so I hope that as the vaccine gets distributed, there are just chances to talk to people and have them understand that, getting a vaccine is not about your individual health, but it's about your participation in the broader goal of community health, and using this as an opportunity so that when the next pandemic or next issue comes up, people have a better foundation for thinking about what are the actions or steps that I need to take to not only protect myself, but the people around us. And with that stronger foundation, and hopefully we can be better prepared to deal with future public health challenges.
Yeah, so Erica, let me come to you. I mean, you're sitting in the catbird seat, and I imagine you were keeping a list, like when the storm subsides, here are the things that we've got to do different and better. What's on your list? What have you learned?
Yeah, I think to kind of highlight or respond to a couple issues that have been brought up, I think two big ones are just, as Art was saying, infrastructure. And I was on another national call with other state health officials, and we talked about public health has single-handedly kept the fax industry alive for much longer than anyone else is using it, right? People were giving vaccines and we're still filling out these little cards, right? I mean, and this is why we don't have good data. So I think, and I'll just put my pitch in now, and we are making these big pitches, and we've made them as Art's saying, for, ongoing, but hopefully this time people will listen. Like, you need to invest in advance in health and public health. I think, back to this other kind of individual versus community dichotomy, I think we really in this country have really put all of our dollars into individual healthcare and sort of medical care once you're sick, rather than the prevention dollars. And we continue to need to make a better case on the return on investment on prevention and public health and that infrastructure. So that's I think a huge lesson learned that I hope that we're making the request, and I hope people will respond to the investment, literally the financial investment and the infrastructure investment we need for the IT structures, the epidemiologists, the workforce. We don't have bench strength at all, right? We could barely had enough staffing, I think, at the local and state level to deal with sort of the ongoing reportable communicable diseases, much less the magnitude and scope of this pandemic. And then I think the other huge, unfortunate area, but where we, I think, are going to really have learned a lot and done a lot in California to move us forward is, and it sort of all wraps into this idea about hesitancy as well, but really the inequities and the disparities, right? This pandemic has magnified, right? It's really been not just a pandemic of disease, but of disparities and disproportionately impacting people with the disease itself, and then also the impacts of our interventions as far as staying at home or certain businesses being out. That's disproportionately impacted. So I think what we didn't start out well in California, but I think, this idea of equity metrics. So moving our blueprint forward with the testing positivity, health equity metric, and now our vaccine health equity, benchmark. We just on Friday hit our 2 million mark of 2 million doses in what we call the Healthy Places Index, least advantaged quartile. And really, tying this all together in that we know that, for example, 40% of the cases, hospitalizations, and deaths in California are in our least advantaged quartile. So we should be putting 40% of our vaccine allocation into that. And we are starting to do that now. And as Coco and others have been pointing out, it's not just, just because you bring the vaccine to a certain area doesn't mean the right people who want to get it are going to get it, because other people who have more resources and can look it up on the internet are going to come find that. I mean, we're all reading these stories in the media as well, right? So we have to go much above and beyond. We have to work with our trusted messengers, our trusted community-based organizations, other people on the ground who are already working with different populations. And that is not always fast, right? Back to the sort of criticism about how slow are you, how much of the vaccine are you using? I think we do have a game changer as far as our Johnson & Johnson vaccine. So again, super exciting that is a one dose. It's much more easy to transport and store. So I think that's really great. Hopefully more of that on the horizon. But so as far as the other lesson learned, and as I think about, as the pediatrician and infectious disease person thinking about pediatric vaccines down the line, we need to start with HPI quartile 1 first as a way to really prioritize. And, part of this was that we started out this time with healthcare workers, which already at baseline, because of our other underlying structures that have led to that being disproportionately in our kind of most advantaged quartiles. But I think that's where we are behind, and we really need to catch up on that as far as some equity. I think, and at this point we're working on equality, not quite equity, but really working towards that. So that's a huge lesson learned that I think we need to continue to attend to. And I think we haven't done it out front the way we needed to in California, but at least we're there. And I think we're one of the only states that's really made such clear benchmarks that the whole state has to follow, or each whole county has to follow in order to really move forward.
Yeah, great. I want to talk a little bit more with all of you about the equity issues and also about hesitancy. Then we're going to turn to questions that are coming in from folks that are watching. And again, I'll remind people who are watching, feel free to post your queries to our Facebook Live streaming site. Let me go back to equity. And Coco, I would like you to weigh in on this. I feel a little whipsawed about the equity issue. One day I read, about a state where there seem to be very justifiable complaints and concerns about racial equity. And then another's, well, wait, what about pre-existing conditions? What about age? What about rural versus urban? What about occupational equity? There's so many different vectors. There's so many different equity lines that have been at times presented as a zero-sum game. Well, if you're being racially equitable, that means you must be inequitable when it comes to pre-existing conditions or older people. Help us. I'd like all of you to sort of weigh in, but let me start with Coco. How do you think about this? How do you make sense of that equity issue that's cutting across so many different levels of disparities in our society?
I think that that first of all, that's like the big question right now, right? And it's the big question because of supply and access channels. So if we had the supply for everybody and everybody could just roll up their arm today and get a vaccine, this would be a non-issue. So unfortunately, we have a culture of scarcity right now with vaccines. And when there is a culture of scarcity, then it pits us against each other. And that's not that's not really that helpful. I think the kinds of metrics that Erica is talking about and the work that she's doing, is the kind of work that makes me really proud to be a Californian, really proud to have trained with Erica. That kind of work just is fantastic. And, I think we have to look at risk, especially risk of hospitalization and death. The challenge is that, and this is where, as a clinician, you have the individual level, and then a state, when you're dealing with big systems, you have to draw lines that don't necessarily work for everybody. So for instance, because I'm a pediatrician and I'm an adolescent medicine doc, one thing I've been thinking about is, this line around the age 16. So I'm not saying teenagers should be number one, but just in terms of 16-year-olds being eligible for vaccines and people under 16 not being able to get vaccines, that's a random number that's been set because we need a number. But if anyone remembers middle school and high school, 16-year-olds do not all look the same. So there's 16-year-olds who look like fifth graders, and there's 16-year-olds who could be bouncers. And similarly, there's 16-year-olds, who look like they could be a mom, and 16-year-old girls who, could only be someone's kid. So and that depends on your maturity, and that maturity is not set by age. It's set by one's own individual timeline through puberty. And so that's not as relevant right now to what you're talking about right now, but it has to do with, you have to make a line, you have to make a guideline. And so I think this is where it's really critical that we not be polarized and that we work together as communities, knowing that we're all doing our best, first of all, to be sure that everyone gets vaccinated, and second of all, to be safe in the meantime. Because if we follow the measures we're supposed to follow in terms of hand washing and distancing and mask wearing, then the urgency is not as intense. And so I think if we feel like we're keeping each other safe, then it's like with HIV, there's the behavioral modifications and there's the medical modifications. And we spent a lot of time arguing about the two when we've learned that actually you have to do both. And so it's the same thing. If we do both, we can keep us all safer as we all get vaccinated. And we don't want to do anything in the meantime where we're going to look back when we're all vaccinated and go, wow, I wish we hadn't gotten into it that way. So I guess that's my simplistic way of looking at it.
So I want to turn to Art and then Osagie. Art, how do you think about this? Is equity a zero-sum game? Are we getting this right? Should it strictly be about risk of hospitalization? How do you think about that?
Well, last summer on this National Academy Committee, I sat through many hours of meetings with ethicists galore and people arguing about, what should the priority be? Reducing deaths in the elderly, reducing transmission in disadvantaged communities, protecting healthcare workers, and to a certain extent, these categories overlap, but in many ways they don't. And so even in those discussions, I think people of goodwill disagreed as to what the highest priority should be in a time of scarcity or limited numbers of doses of vaccine. To me, what's, as I said, interesting, if not a little distressing, is the extent to which fundamentally all of those guidelines that people came up with have largely been superseded by often political considerations. And so if one group, yells at the governor enough in a particular state, magically the next week they're included, not necessarily justified on grounds of morbidity or mortality or hospitalizations or equity, but just because they had a good person lobbying for them at their state capital. And I'm not talking about California, I'm talking about all 50 states. So I think, that you might say, well, that's the reality of the world, wake up, but I do think that it does say that this is a very difficult thing to do and to get right. And I don't think we've done a particularly good job here in the United States of getting it right from the get-go. But within a few months, presumably, most of these differences of opinion will largely be academic.
So that raises Osage, let me come to you for sort of the give you the last word on this particular issue, though of course we can come back to it. Given that we're just around the corner and the president said we're all going to be eligible by May 1, is the equity issue receded in importance for you because it's just a matter of time? How are you thinking about the equity issue right now, given the evolution, given the rollout, and given these sort of conflicting ideas of what is equitable?
Yeah, so I think it's important to have a nuanced understanding of equity and exposure. So, for example, someone who is over the age 60 might have a particular risk with regards to COVID-19 that should be taken into consideration. However, someone who's over the age of 60 and works in an environment where they're in close contact with people and lives in a neighborhood that is particularly susceptible and lives in a multi-generational household has several overlapping issues concerning equity that makes that person particularly vulnerable to COVID-19. And so that's where it's important to try to identify those people who have more than one identity trait or life experience that makes them particularly vulnerable, and make sure we highlight those folks because they're the most likely to be at risk, and then kind of work backwards from there. And that's where I think it's important to kind of move away from the kind of zero-sum game framework that you described at the beginning, Dan, where it's just kind of like where you have individual categories of risk competing for importance, and trying to identify those folks who have overlapping multiple life experiences or traits that makes them particularly vulnerable to COVID-19, making sure they are prioritized, and then working back to then make sure other folks have access to the vaccine.
Got it. Coco, do you have something to add to that?
I think it's I think in terms of the guidelines, it is confusing because different states have different guidelines, but there's a lot of good news. The access has increased a great deal in California as of today. And so thinking about who's eligible is really important, but that's only going to decrease with supply. I think in the meantime, it is really important to think about, are the people who are eligible able to get the vaccine? And while completely agreeing that the glass is half full, and I'm so proud of what's been done in California, I think that's where we need to move quickly. And I'm finding myself thinking about vaccination less like a pediatrician, where I want to have records and I want to have identification and I want to have specific information, or have people get vaccinated in specific places that are more clinical, those kinds of things. And I'm thinking about it more like voting. And I'm thinking, like, if Stacey Abrams organized vaccination, what would it look like? You wouldn't make an appointment 10 days from now and then show up. I can't count on a unstably housed youth or someone who has, a job where they can't control their hours. I can't count on being able to do that. I know I'm supposed to get vaccinated on Saturday. I don't know the time, but it's okay because I still have the same phone and I'll get the message and someone will tell me. So I think thinking about, how we can decrease those barriers by having, walk-in clinics, by not needing an ID, which I know I needed to have, and then also by going to where people are. And, we're seeing that happening where people are going to apartment buildings where seniors who are low income live, or people are going to encampments, or people are going to communities of color and working with the folks in that community. So it's like voting, where you can go in your neighborhood, you can walk up, you don't need an ID, you don't need an appointment, and it doesn't compete with getting your basic needs. It doesn't compete with going to work or taking care of your kids.
Got it. So we're getting a lot of questions about vaccine hesitancy and skepticism. I mean, we've always known there have been anti-vaxxers. Vaccines are part of some nefarious plot to reduce the world's population and carbon emissions. Who knows? And there's now vaccine resistance. It's not that I have anything against vaccines per se, but these are so new. And then there's sort of vaccine skepticism. Yeah, I believe in vaccines. I just don't think it's that big a deal. part of me says, look, there's some legitimacy for the skepticism. We don't have long-term data about the new vaccines, a new technology. What do you say to people who express concerns? Art, let me start with you here. What's the message for people who are skeptical or reluctant, who aren't in the camp that say, no way, no how, I'm never putting it? What do you say to them?
Well, I'd make two quick comments. One, I think the question about long-term safety, frankly, is a bit of a canard. I would point out that there is not a single vaccine that we give to people where we have ever had long-term safety data in the form of decades of follow-up. So if I give you measles vaccine as an infant, will it cause you to have Alzheimer's disease when you're 75 or a heart attack when you're 45? We have no such data for any vaccine, and it's a completely unrealistic standard. What we do know is that all of the known safety problems, if you will, or adverse events related to immunization that have been documented occur within 8 weeks of receiving a vaccine. And we know on that basis that these existing COVID vaccines that are authorized for use and being used are safe with regard to short-term safety. But to say, I want to know that it's not going to do something terrible to me 20 years later is a completely unrealistic standard for introducing any new vaccine.
Got it.
And the only other thing I would say is, based on everything we know, the benefits of being vaccinated far, far, far outweigh any known or likely risks of vaccination.
Got it. Erica, let me come to you next. What's the state of California doing to try to get as many people as possible to line up and get the shot?
I think there's, a multi-pronged approach to that. I think, a lot of what Coco sort of just mentioned are key components of that, right? Working with the right providers, having local health departments or others working with the right providers and communities to bring vaccine to where people are, and then answering questions, right? I've heard another colleague, when several of us got our Johnson & Johnson vaccine on Thursday, talk about it's instead of calling it vaccine hesitancy, it's actually wisdom and trying to ask questions and curiosity. And I think certainly because it is new, and to your point, we want to make sure people are getting their questions answered and getting good information. I think the hard part, again, is how much misinformation is out there. So really helping make sure people get good information, get it from people that they can trust or indirectly that they can trust. I think the other thing, just to talk about risks and benefits, Art already mentioned this, but we also don't know the long-term effects. More importantly, we don't know the long-term effects of COVID infection, right? We're learning more and more about people who are, the sort of long haulers or whatever we're gonna, sort of call it. But we don't know, and that's actually really scary to me. Whereas we do have all this history with vaccines, as Art said. So I think that's one key thing. But I think really just making sure, and the more kind of what I really worry about, and I'm glad we're talking about the hesitancy and equity, is that, there's some, occasionally people are when we were first really saying we need to allocate more to certain populations, right? Because we know, again, that we'll all get through this pandemic faster if we vaccinate where the most disease is, right? That's better for all of us as a community. And then there's, some response of, well, but what if people aren't going to take the vaccine? And you have to make it accessible. You have to give people good information. So I think we're really trying to do that, again, balancing this, what can we do centrally and consistently from the state level, and how can we work with and fund and find partners at the local level who can really do that work, who are trusted.
Got it. Osage, I want to ask you about sort of a related issue. Given the fact that we know there's hesitancy, maybe has meant 30, 35% of the population. I know that varies according to demographics. What about this whole notion of incentivizing or punishing? So I just heard the podcast from the New York Times this morning talking about Israel that has the highest percentage of vaccinations, and people are getting a green card, and some employers saying, no, you can't come back to work, and no, you can't get on this plane, and no, you can't come to this concert. Really sort of shutting people off and creating disincentives, or maybe incentivizing. Ethically, where do you fall out on the extent to which we should have consequences for people who don't vaccinate?
So I think it's an important conversation, and I would reframe it from a conversation about consequences to thinking about what are the public health conditions for someone to participate in civil society. That is to say that we already have existing rules for what are the ground rules for someone to be able to, for example, go to school. We want our school children to be vaccinated. We want to make sure they're not going to school or public places where they're spreading diseases or susceptible to catching certain diseases. When we go to work, we want to make sure that people are also healthy individuals and not bringing communicable diseases to the workplace. And so COVID-19 is just part of that existing conversation about making sure that when people go out into civil society, that they're not causing a public health threat. So part of that conversation can be, should the government or private businesses make certain standards about what it means for workers or school children or anyone else to fly a plane or go to a movie theater or go to a concert, simply as part of the broader conversation of minimizing risk and spread. And so this is not a new conversation. Again, this is an old conversation. It's just a matter of adding COVID-19 into that existing discourse.
Interesting. I want to go to some of what I would call brass tacks and very important questions that are coming from people that are watching. And let me start with this one. If we're being told we can theoretically still be carriers and infect others, even if we are vaccinated, does that mean that vaccination is really only to protect the individual receiving the vaccine? Art, let me start with you on that one. And if anybody else wants to weigh in after Art, just put your hand up.
Well, just very quickly, I would say so far the evidence, in fact, is that successfully vaccinated people with the existing vaccines are highly unlikely to become infected or infect other people. Now, will that be true 6 months after vaccination or a year after vaccination? Will we need boosters or variants going to change that? Those are unanswered questions. But at the moment, I think, in fact, the risk of a successfully vaccinated person becoming infected and transmitting to others is extremely low.
Got it. Anybody else want to add into that before I move on to the next one? Good. All right. So the next one is, I'd like to know if those of us living in households that have some vaccinated and some unvaccinated, maybe because they're not yet eligible, whether we should be taking extra precautions at home, especially if the vaccinated person works in public daily. There hasn't been any focus on this sort of blended situation. So Erica, let me ask you about that. I say you're kind of, gave you some food for thought. What would you tell this person?
Yeah, no, it's a great question, and I'll just be very personal about it. I'm thinking about, I actually literally just got vaccinated a few days ago, so I won't be fully protected for a couple weeks. My husband is a healthcare worker, has already been vaccinated, but I have 2 children who are not yet of age, and we haven't thought about that at all. I think that the great guidance that came out, just also to speak on a more personal level, is if you're fully vaccinated, you can visit one other household that has unvaccinated persons if they're not at high risk for serious complications or infections. So this is really geared towards, and we took advantage of this in our family recently as well, of grandparents who are fully vaccinated. We're now saying can see their grandchildren even if they're not vaccinated indoors. And again, I think so. You're already taking. It is hard, and I think there's guidances on the other level of people who are infected and known to be infected, and how to try to, once you're known to be infected, how do you try to, within a household, try to, have your own room and stay separate. And, it's an airborne disease. This is really challenging. I think outside of knowing you have an infection, it's a really challenging thing to ask people to do. And as we kind of are alluding to, in certain households are not going to be able to do even that with known infections. So I think right now, I think people are just going to, I think, as Art was saying, I would just echo that more and more evidence is showing, and certainly with prior vaccines, that we don't think people are going to be able to be infected while they're vaccinated, after they're fully vaccinated and protected. Right. So right now there's no special guidance for that. I think, just keeping it in mind, and this is top of mind as we think about school, coming up in the fall, right? We're going to hope that our teachers are protected, but the kids still won't be kids under 12. I think we'll get more of our teenagers vaccinated before then, hopefully, or at the beginning of school. But we're going to have that scenario. And so I do think, actually, my last comment on this is that outside of the household, we're going to be, I think we're going to be seeing masks in our future for a while, until we can get our kids vaccinated, certainly outside of the household. But I think your home, it has to be your sacred place where it is really hard to ask people able to do masking at home. I do think when people have high risk people at home, and if there's a lot of exposure, it's something to consider. And I think that's a harm reduction message we have worked on for certain populations. If there are, someone who's working outside the home in a high risk setting, and then someone who's elderly at home, who, especially prior to having opportunities for vaccination, that you would try to really keep people separate or have masking in the home. But now that, especially if the other people are low risk, I think there's no need to have any other special precautions in the household.
Erica, I want to follow up, and if anybody wants to weigh in afterwards, we keep talking about kids, but when are they? When do you think they will be able to be vaccinated? I've got a 13-year-old at home who's never wanted a shot more in his entire life. There seem to be some clinical trials underway, but uncertain about what the timeline. What's your read, Erica, about when we could expect to have children lining up as well?
I will start, and then Art may have a better insight into this than I do. I think there are definitely, to your teenager point, there are definitely trials now with 12 to 16-year-olds. So I do think, relatively soon we will have more data in 12 to 16-year-olds.
What does that mean? What does relatively soon mean?
Well, we started our trials for the adults this past fall, right? We were able to get it out at the end of December. So I'm hopeful sometime this summer, right, that we might be vaccinating teenagers. And again, I'm curious to hear what Art says about this. I think younger children, we're not, I don't think anybody's enrolling yet under 12. So I think that's going to take several more months. And, I've heard actually others speculate early 2022 is probably around when we're going to see younger children actually be able to be vaccinated. So I think we have longer to wait for younger kids. But yeah, others, please feel free to add.
Art, you want to throw in on that?
No, I agree with what Erica said. I'm cautiously optimistic we'll be vaccinating teenagers over the age of 12 before school begins or near to when school begins, but not younger than that.
Let me ask you, throw this out for whoever wants to answer, just about efficacy given the variants. So I don't know, a couple of weeks ago, I read a column in the New York Times that said, the coverage of the vaccines is way too negative about the variants. Yeah, you could still get sick, but they're going to completely protect you from hospitalization and death. A week later, The Atlantic runs a piece. The coverage about the vaccines and the variants is way too positive. It's way more. Okay, we're confused. In terms of the variants that are out, how effective are the current vaccines? How important are boosters going to be? And to what extent does this mean we're going to be living with coronavirus for the rest of our lives? Art, I'm going to come right back at you with the hard one.
So first of all, the variants that are currently known, the existing vaccines are still quite good at preventing hospitalization and death, which are the outcomes we really worry about. This virus will perpetually spin off new variants. And what I just said may not be true 6 months from now with other variants that we have yet to see. So will there be a need for annual immunization or boosters, or nobody knows. And anyone who says they know is basically blowing smoke. We have a lot to learn about the virus, but I would say so far, the vaccines we have will provide good protection against the variants we know about for the outcomes we really care about.
Anyone else want to weigh in on that one before we move on? Erica?
I would agree with that. And I think that's an important message. So you, again, are seeing some of this data saying, well, it's sort of like when we're comparing the Johnson & Johnson, just to speak to that, because I know there's a lot of questions, Johnson & Johnson vaccine efficacy versus some of the others. You might see lower numbers for overall infection, but when you really look at hospitalization and death, which is, again, what we really care about, right now we're seeing, and more clinical data. There was some more speculation for just in the lab, but more and more clinical data to show that. So we are reassured by that, and the fact that if we can continue to vaccinate more people and decrease transmission, it will allow, the way the virus is going to mutate is if there's a lot of transmission, right? There's going to be more mutations if it's really surviving, and so if we can interrupt that and interrupt any kind of mutations, both from just ongoing transmission or sort of vaccine escape, by decreasing levels, by getting people vaccinated as quickly as possible and continuing our masking and everything else in the meantime, we will decrease the chances of further. Although I also agree with Art. I think, I foresee this as a vaccine preventable disease. I don't think it's ever ever going to go away. It's way too smart of a virus. We haven't been able to get rid of flu, and this is a much smarter virus. So I do think it's with us, but I think we can continue to have all the tools that we have and are increasing to have to fight against it.
Got it. Osage, I want to come to you. There was a follow-up question. We were talking about ethics and about the passport, and this one's a little more specific. And it was, do you think that it is ethical for employers to require that folks get vaccinated unless they have a medical exception for the greater good of society?
So that's a difficult question, because you have employers that hire 2 or 3 people versus employers that hire several thousand. So I think it all depends on the workplace and what workplace you're in, the contact that employees have with one another and with the public. And I think that's where local public health departments have to provide guidance on what employers can and ought to be doing with regards to requiring vaccination.
So you're it seems like a gray area for you, that it might not be ethical for an employer to say, no, you can't come back to work without a vaccination.
So I think the question of whether it's ethical intersects with the question of whether or not it's necessitated by the public health mandate. And so this is not simply a question about kind of ethics in a theoretical sense. It's really an empirical question about how public health professionals think about the spread of the disease and what are the particular contexts in which it's more than likely to be dangerous, both for employees and the public. And so again, not all workplaces are the same. I'm a professor. I work alone in the office for the most part. I have singular interactions with my colleagues and students. So that's quite different than someone who works in a large warehouse, let's say Amazon warehouse, where they're in contact with hundreds of different people, in theory, over many days. And so that's a different type of risk. And so this really has to be a question about what steps are necessary to prevent further community spread. And that's an empirical question as much as an ethical question.
So I want to follow up and come back in a slightly different context, talking about, I don't know, a large public research university with 40,000 students who are intermingling, who are living in congregate settings, who are sitting in classrooms. Do you think colleges and universities should be requiring vaccinations for students who want to return to campus next fall?
So that's a particularly difficult question, because we have so many different people from different age demographics with different levels of risk and exposure. Berkeley has 30,000 undergraduates, I believe, several thousand faculty and staff. And so those type of mixed situations are quite difficult. So my understanding is that this is a conversation that the university is actively having right now. So I wouldn't presume that I should be publicly commenting on that right now in terms of what they have to do. But it is to say that university settings are unique, particularly large public universities, and they have to take into consideration that their constituencies are people of diverse backgrounds. And so it's a really difficult question about what's the best way to protect all the various stakeholders that we interact with.
Dan, if I might just chime in, there's also the legal question.
Mm-hmm.
And my understanding is, as long as it's only authorized under an EUA, it probably would not.
Wait a sec. Acronym alert. EUA is what?
Under an emergency use authorization. It probably would not stand up in court to require people to get the vaccine. But once it has full FDA approval, my understanding is that the lawyers say you can certainly do it legally, if not ethically.
And when's that going to happen? So I think, I actually forgot all of these vaccines were emergency approval. When are they going to be?
My understanding is that the Moderna and the Pfizer vaccines are likely to come back for full approval in June. But I don't know if Erica knows. Well, you just asked me that question this morning. So
I just emailed it.
Is perhaps June.
But I think there's precedent, just to quickly throw in, there's precedent, right? I think, and UC has been a model, I think, for requiring measles, I believe, and meningococcal vaccine, right? So there's a precedent for other less infectious diseases. Well, measles has a higher attack rate, but it's a different.
Even influenza.
And yeah, so I think there's certainly a precedent for sure. I think this is the legal issue. So yeah.
Yeah. And this is what I was mentioning earlier, is that it's not uncommon for schools and workplaces to require vaccinations and other public health requirements before people can participate. That this is something that we've been doing for a very long time. So I think we have to kind of change the conversation from saying that it's unprecedented for any employer to require an employee to be vaccinated. That's simply not true. And that we have these existing rules and practices that we have been doing for a very long time. And this is just a new entry to that conversation.
So we are just about out of time. Suffice to say, I think we could easily go another 2 or 3 days on this subject. But I want to end by going around the room one more time. And I want to start with you, Coco. What are you going to be looking at in the days, weeks, and months ahead? What should we be paying attention to? What will you be paying attention to? In the vaccine context, of course.
Well, I've been talking a lot about the multi-level challenges that we have. So obviously I'll be looking at how we respond to that. I think I'll also be looking at the messaging. I think as a pediatrician, I've talked to a lot of folks about their decisions to vaccinate or not vaccinate their children in particular, or even themselves. And I think people often decide between, do I want to get vaccinated or do I not want to get vaccinated? And they're thinking, what's the risk of putting this strange substance in my body versus not putting that substance in my body? And they're not thinking about what's the risk of being in this world with this new infection in it and getting vaccinated versus being in this world and not getting that. And so people are not comparing the right elements. And I find that when I talk to parents who are, thinking about whether they want their child to get a measles vaccine or not, I say not getting a measles vaccine if there was no measles would be really smart, because why would you stick this stuff in your kid's body if there was no measles? But there is measles. And it's the same thing with coronavirus. There is coronavirus. And so now what is our decision for our own health, for our family's health, and for society's health? And I think we need to start thinking about comparing the right things and having the messaging out there that compares the right things. Then I think we'll get to a better place.
Great. Erica, I know it's a really unfair question because there isn't any one particular thing. You've got to look at everything. But if you have to pick out one thing as the state epidemiologist, what are you going to be really tuned into in the weeks and months ahead?
I think I really want us to get to our equity goals, and not just sort of the actual benchmarks, but really looking and attending that, so now we're allocating more, but are we doing all those other things we've talked about to get vaccines into the people we think that, have been disproportionately impacted again from this pandemic. And so that's what I'm really keeping my eye on, as well as, I really want us to continue to get vaccinated as quickly as possible to kind of, stay hopefully this time one step ahead of this virus. Because, I think as we start to reopen, which we are starting to do, if people let their guard down, then, it could get ahead of us again. The other deja vu, maybe I already said it earlier, but Italy is having another lockdown, and that was happening just over a year ago. So, I'm really hopeful that we can continue to stay patient as a state and as a community. And the Bay Area, of course, is the model. I'm biased to this Bay Area bubble of, I think people are really have been very patient and continue to do so. But so those are my two things. And before I end, I just wanted to say it's been such a pleasure to reconnect with Coco, who actually was a mentor of mine. And I've gotten to work more closely with Art now with the Western State Scientific Review Group, but he's been a mentor of mine as well. So really a pleasure. And nice to meet you, Osagie and Dan.
Yeah, thanks. Art, final word on the same subject. What's on your wish list weeks and months ahead?
A wish list, a much higher proportion of people vaccinated, much lower hospitalization and death rate, and a disappearance of the political nature of who's getting vaccinated and who isn't.
Got it. You're getting a lot of thumbs up from everyone, the other panelists on that one. And Osagie, I'm going to give you the last word there. What are you going to be focused on, really interested in as the vaccine rollout continues?
It's one word: leadership. Who's going to step up and be the adults and lead on this conversation, both at the community level and the national level, and show that vaccinations are an important part of a broad public health strategy to make sure that we can get back to some sense of normalcy. And my hope is that as the political climate hopefully becomes more sensible, that people will simply be more thoughtful about leading, again, at multiple levels: community, state, and national levels, and really make sure that we can have a sensible conversation about an urgent public health need.
Got it. I want to thank you all for what has been really, really, truly a spectacular conversation, highly informative. We're grateful that you could join us. I know you're all super busy. Want to thank everybody out there for joining us. Be well, stay safe, and when you can, please get vaccinated. Thanks again.